Okay, there we go. Okay, so I know we have a few new folks, so I'll just kind of introduce myself and Dr. Stoll and what this group is about, and then we'll kind of jump into Kelly's talk today on CBT for patients with chronic pain. I am Will Schmeckley. I'm a project coordinator at the Nebraska Medical Association. Dr. Todd Stoll and I work on this integrated healthcare project, which provides some startup funding for medical sites and behavioral health providers to integrate and work together. Mostly what we do is kind of clinics access some grant funds we have to hire behavioral health providers. And then this meeting is just kind of a meeting invitation that goes out to all the sites we work with. So we've got some medical providers here, some behavioral health providers, mostly behavioral health providers. And we kind of do this monthly meeting where we offer some education, kind of a chance to have some discussion occasionally if time allows it. Um, Rather than go around and do introductions, just to kind of save time, if folks want to just go into the chat and just kind of drop in where you're coming from and what your role is. And again, I'm Will Schmeckley at the Nebraska Medical Association, so I'm located here in Lincoln. Okay, I think we can get going with Kelly's talk today. So I'll just quick introduction for Kelly. She's a private practice, LIMHP. Before that, she was, I don't know if I got your title right, Director of Behavioral Health Services at One World. Is that more or less? Yeah. So she's, One World is a community clinic, federally qualified community clinic in Omaha, which does a lot of behavioral health integration, has a large staff of mental health therapists and such. Kelly oversaw that program before moving into private practice. And then she's here today talking about CBT for patients with chronic pain. And this topic kind of came up. We at the Dr. Stoll and I at the NMA here partner with Department of Corrections, and they reached out to us looking for someone to talk on this topic. And we were kind of stumped. Dr. Stoll knew Kelly from kind of professionally from his time in Omaha, so we reached out to her, and she was nice enough to put this talk together for us. We thought it'd be a relevant topic for this group as well, so we invited her here for that. And I'll turn it over to you, Kelly.
Okay. Yeah, thanks for having me. I'm happy to be here today. I'm going to try to share my screen here with PowerPoint if it's hopefully going to let me.
You should be able to. There we go.
Okay, can you see it?
Yep, that looks perfect.
Okay, great. Okay, so as Will mentioned, I'm going to talk today about cognitive behavioral therapy for chronic pain. And I'm going to shorten that to CBT-CP, and that's what it's generally referred as. So a little bit, just today, we want to just kind of go over a basic understanding of that biological relationship between emotional experiences and physical experiences for clients with chronic pain. I'm going to explain how to conceptualize chronic pain using that CBT-CP model, and hopefully come away with understanding at least like one behavioral and one cognitive intervention from this model. So, what is chronic pain? It's really important to understand pain to do this type of work with your clients. So, this definition of pain by the International Association for the Study of Pain was released in 2020, and it was the first revision since 1979. And it was really the result of a 2-year process that the association would hoped would lead to like better ways, revised ways of assessing and treating pain. So their definition they came out with is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this definition emphasizes that pain is a personal experience influenced by biological, psychological, and social factors. What is different that they also came out and expanded upon the definition with these 6 keynotes. That pain is always a personal experience. that is influenced to varying degrees by biological, psychological, and social factors. That pain and nociception are different phenomenon, and pain cannot be inferred solely from activity in sensory neurons. And nociception is just the physiological response to stimuli. Their next note is through their life experiences, individuals learn the concept of pain, that a person's report of an experience as pain should be respected, and that although pain usually serves an adaptive role, it may have adverse effects on function, social, and psychological well-being. Verbal description is only one of the several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences pain. And there's also, oops, sorry, hold on a second. Okay. So we also want to talk about the difference between acute versus chronic pain. So in here, acute pain is like the pain that occurs suddenly. It's usually sharp or intense. It's acting as the body's alarm system to indicate that something is wrong. So it typically lasts from like a few minutes up to 6 months, depending on the cause, and generally resolves once that underlying issue is treated or healed. So unlike chronic pain, acute pain is temporary. It has this clear, identifiable cause. So most commonly, we think of these from like injuries or maybe post-operative pain from surgery or medical procedures. Chronic pain is a pain that persists or recurs for longer than 3 months. That's kind of the standard time frame. And such pain often becomes that sole or predominant clinical problem in some patients. So it may warrant like specific diagnostic evaluation, therapy, and rehabilitation. And it really is a frequent condition. It's affecting an estimated of about 20% of people worldwide. Here's the common types of chronic pain. So they put them in these categories. Chronic pain is kind of an umbrella term. It's not really a one size fits all. Here are only 7 different categories. Some of these also have umbrella terms for conditions that fall within them. Chronic primary pain is obviously one of the most, umbrella terms where a lot of different things, and you may see the majority of your patients fall into this category. That's that pain that persists or recurs for longer than 3 months and is characterized by significant emotional distress. So maybe like anxiety, anger, frustration, or depressed mood, or functional disability, right? Interfering in daily life activities, reduced participation in social roles. And it's really getting to the fact that there's more than just pain or a physical experience. There's cancer-related pain, post-surgical or post-traumatic pain, neuropathic pain, secondary headache or orofacial pain, secondary visceral pain, and secondary musculoskeletal pain. In the secondary musculoskeletal pain, there's another common type you might see in here, arthritis, often like low back pain, shoulder, knee pain, things like that. With arthritis, mental health treatment is usually recommended because it can help people adjust and make those lifestyle changes that are really needed. Another condition that fits within that category is also fibromyalgia. It usually gets categorized here, generally just because how it's treated. This is probably the most chronic pain issue that I see in the patients that I treat, along with that general primary pain, also a lot of like headaches, migraines, and then fibromyalgia. This is that widespread pain, tenderness, fatigue, sleep disturbance, memory complaints, kind of that fibrofog syndrome, and mood disturbance. It is a condition of the nerves and nervous system. The nervous system becomes really hypersensitive, causing pain, maybe in the face of stimuli where it shouldn't be painful. Like, for example, like if somebody would be walking maybe through the freezer section of the store, normally you would just feel that cold sensation, whereas that stimulus might get picked up in the body and interpreted as pain. Also, commonly what happens is like sensations that should be painful do get amplified. So it's not necessarily something in somebody's head or that they're trying to exaggerate. It's just where even maybe slight pressure, something gets picked up as more and might be uncomfortable or even painful. So with fibromyalgia, we see that highly comorbid with depression Anxiety and CBT CP is recommended along with medication and physical therapy. So why use pain-focused psychotherapy? So there's a lot of reasons. Obviously, there's been the war on opioids, right? That led to really significant policy and law changes that resulted in people being taken off those medications. A lot of people with chronic pain were kind of left in distress. They didn't have the medication, so they experienced more pain, and they really didn't have a lot of additional tools to manage it. Also, with long-term opioid use, there is this phenomenon where the body can become like hypersensitive to pain. So the nervous system starts to become oversensitive. The body tries to keep homeostasis, right? It's trying not to feel as much pain due to the opioids, but the body then thinks it's not processing pain correctly. So it actually tends to become more sensitive. Sometimes asking patients about this, asking them and having those conversations, like if they realize opioids could be accidentally making their pain worse, they could potentially become overly sensitive to pain signals. So maybe things that they used to rate a 6 could now feel like an 8. Also, people are just looking for alternative methods to manage and cope with pain, associated depression, and other mental health symptoms. And it's really a biopsychosocial issue. It affects the person physically, psychologically, and how well they cope. Affects family and other relationships, often their work, and their sense of self. They're no longer able to do things maybe that they used to do, or even things they enjoyed. And of course, all this then affects their mood and is a whole person issue. So the impact of chronic pain, we see like a lot of loss of hope, loss of control, inability to function, or that perceived inability to function, which often leads to the depression, anxiety, anger, decreased quality of life. Emotional distress can contribute to maintaining pain and create a cycle. Pain psychology is really focused on managing those emotion things, anxiety and depression. It's about providing behavioral interventions to try to counteract those unhelpful pain behaviors. A lot of psychoeducation about the biopsychosocial aspects of pain, really trying to help patients become aware of that relationship between their mental health and their physical health. It's a fully integrated approach using CBT, relaxation training, some self-management and behavioral skills training, and that cognitive restructuring. So it's helpful to understand how pain processing works. And I would say, if you're going to work with clients on their chronic pain issues, I would really understand this. We're not going to go into all the details of that today, but just understanding like maybe how the process is of pain in the actual body, right? This is kind of just a very simplistic picture of like pain in the nervous system, where those physical sensations are picked up in receptors and nerves and in the skin and muscle tissue. It goes up to the spinal cord and the brain, where those pain signals get processed, and then of course sends messages back down the spine through different nerves and muscle tissues. And so that's a really simple explanation, but sometimes having a lot of psychoeducation in this model is really helpful for people to even understand like how their body is receiving pain, and then how those behavioral interventions really can help them manage that. So pain impacts psychological factors, right? And then those psychological factors also impact pain. So there's a few areas we see this a lot, right? Learning is one of those. So modeling, or like our cultural learning. So we learn this by watching others. Of course, in like this Western culture, when we hurt, we don't feel well, we're supposed to rest. We're often also taught to go to the doctor, right? The doctor's going to make us feel better. With chronic pain, that isn't always the case. Also, with chronic pain, doctors aren't always able to help the pain, and extensive rest is actually contraindicated. So it's important to know, like in your patients, like maybe what their culture says about pain, what their culture says about healing. That's going to play a role in this as well. Classical and operant conditioning, right? When something is painful, we want to avoid doing it. So we avoid those aspects of life, often that are important and meaningful just because we are having pain. Where we think the pain is coming from also plays a role, or the reason for pain. So if we believe pain is a result of overworking our bodies, we could start to blame ourselves. Or if it might be related to work, we might be angry with an employer, an institution, things like that. If we blame ourselves, that could also lead to that shame, guilt, and depression. Locus of control is part of that, becomes important, right? Internal locus of control is associated with beliefs of better coping. If we feel like we have some control over that, that helps us with better coping strategies. And then stress behaviors also play a role, right? Grinding teeth, you're tensing muscles, which in turn leads to pain. Neurochemicals associated with stress can enhance pain processing. So all of those things actually leading to more pain for the person. So this is just an example to kind of show how like psychological factors just experience the pain. It's just a simple example. Like, okay, let's say this is you today. You've had a wonderful morning. You went for a little walk before this meeting, right? You have this great day at work. You go home and you have things planned and you're feeling relaxed and great. You walk in the door. If you have kids, you know that there's often toys, Legos, things, right? So let's say you walk in the door and you step on this Lego, ouch, right? That hurts really bad. And you say, oh my gosh, my pain, it's like a level 5. But then let's say, a different day, you are stressed, you did not get your walk in before your lunch meeting, work is busy, stressful, you're behind on your documentation, you have a lot of really severe, difficult patients. You pick the kids up and they're screaming in the car and fighting, right? You walk in the house, you step on that same Lego, and maybe you rate it an 8. So it's that idea of like, those psychological factors are really affecting how we experience the pain, even though it might be similar pain. So we can imagine what that might be like for someone with chronic pain, because they're already frustrated. They're feeling negative emotions because of their pain. And imagine what happens when they encounter that Lego or some other pain stimulus, right? So this is why behavioral activation and getting people re-engaged in enjoyable activities and in their life is a component that's really helpful in this intervention, because when we're in a better mood, when we are more positive, when we're enjoying things in our lives, our brains do process pain differently, and pain influences emotions. Emotions influence pain. So it's that cycle. Okay, so now we get to CBT, CP. And most all of you, I'm sure, are probably familiar with CBT, right? That's helping people cope with a lot of problems by changing their thinking and their behavior. It really was originally developed a lot for treating depression, and then, of course, has been successfully applied to the management of a lot of other conditions, anxiety disorders, substance use, eating disorders, and other mental health issues. So this cognitive behavioral model emphasizes that link between cognitions, emotions, and behaviors. And all of these variables interact, and maladaptive responses can create undesirable experiences or patterns. So understanding this underlying theory really helps, because it's closely related to CBT-CP. And we see how specifically behavior can impact how a person thinks, feels, or thoughts. And those can impact how a person responds and behaves in situations. So, you think of like maybe somebody gets up from sitting down or the table, that's kind of like your situation, and, they have leg pain upon standing. And the person feels maybe discouraged, frustrated. Those are our emotions. And they think, oh gosh, if I try to do something today, I'm just going to hurt more. Those are those thoughts, which then lead to maybe staying on the couch or at the table, avoiding moving the rest of the day. And that cycle continues. The biopsychosocial model is generally accepted as the most useful approach, I guess, to understanding those clinical factors associated with chronic pain. It's that interchange between not only physical, but then psychological, behavioral, and social influences, and how individuals experience and report their pain. So those influential factors, we know psychological factors are those pain cognitions, our thoughts about pain. Catastrophizing, we'll go into some of these a little bit more. Hurt versus harm, negative affect, answer seeking, or pain self-efficacy. Behavioral factors are like how well are we able to cope, passive coping, maybe that's rest and underactivity, active coping using exercise or overactivity. Other coping could be like pacing and relaxation training. And then, of course, the social factors. We still have work, family, a social network. And we might get how our significant others or family around us then treats us regarding pain. That influences us as well. So here's the chronic pain cycle. This is the cycle that we want to talk to patients about. There's a lot of psychoeducation in this model on these things. Since chronic pain impacts various aspects of daily functioning in those areas of life, it's helpful to understand the process and the stages that can occur over time. You can see in this figure, it illustrates at the top there, it's like the onset of chronic pain often leads to decrease in activity. And when people decrease their activity, that leads to physical deconditioning, right? So muscles might start to atrophy, joints can stiffen up, and then they continue to deal with the pain, and they leads to negative thoughts. I can't do anything when I have pain, leads to negative emotions, frustration, anxiety, depression. And then these factors, again, increased avoidance of family, friends, maybe anything that involves, movement, since it hurts more to move. And that combination just leads to more distress and disability and increased pain. Most patients are easily able to recognize the cycle in their lives. When you sit down and talk to them about this, they can see. And oftentimes I work with patients to try to label these areas, like what's happening in their own life, so they can make that connection to the cycle. And then that helps us also talk to them about how CBT-CP breaks that cycle. So the CBT-CP model to conceptualize pain is basically the same, right? It looks like a traditional CBT model. We still have the thoughts, emotions, behaviors, all those are interconnected, but now we have the chronic pain in there. So all of these relationships you can see are bidirectional. We have those arrows all leading in all the different ways. So it's not just pain that leads to catastrophic thinking or depression. It's also maladaptive thinking, resulting depression can then make the pain worse. And that's really kind of the point of CBT, intervening at any one point in this model can bring changes to other areas in the model. So the first thing I do with patients is a pain-focused intake. This is really important. A good clinical interview, getting a history of the problem, the impact of pain on their quality of life, and their mental health history. I talk to people about medical interventions, what have they done, what treatments have they had, and things that have improved or possibly worsened the pain, how it's affected their physical abilities, their work, their family, social life, sense of self. And then, of course, we want to look at their mental health history, maybe do depression screenings, substance use, suicide screenings, or safety assessments. These are one of the scales that you can use. It's the pain catastrophizing scale. It's a self-report tool to measure catastrophic thinking related to pain. It kind of scores and categorizes three main areas, that rumination, magnification, and helplessness. So it's helping you kind of assess how patients are perceiving pain. It's on a Likert scale. It's 0 to 4, and you categorize, score each of those subcategories. So with magnification, with rumination, it's the persistent focus on pain. We're looking at that. Magnification, their exaggeration of threat or seriousness of pain, and then the helplessness, if they're feeling unable to manage or control pain. There's a lot of different tools. I find this one really helpful, but there's a lot out there, other ones that are also very helpful. So after that good assessment, good clinical intake, then we have a good idea of how we're going to provide treatment and help that patient break the cycle that we've been talking about. And psychoeducation is a big part of this model. Psychoeducation about pain and the pain cycle is really woven into every session. That's why we're kind of spending so much time on it today, if you're wondering. How the pain and the pain cycle interact with thoughts, emotions, are what makes this different than other types of CBT. And I think the psychoeducation is also really helpful in that rapport building and patient buy-in. And that's why it's really important to start there. And then you can see that after that, behavioral strategies are really important. Relaxation training, behavioral activation, activity pacing, and sleep. And then those cognitive strategies, identifying pain-related thoughts, cognitive restructuring. So here's just some possible formats. CBT-CP is usually kind of like a 8 to 12 session model if you use like a manualized approach. These are the modules that are usually all included in CBT-CP in some way or another, but there isn't just like one right way to provide it. So you can do it in a different order, what you think works best. I actually use more of a format like this because I like the behavioral interventions really front loaded in the beginning of sessions and then the cognitive interventions later. And I find that helpful because it's really good for rapport building and getting people to do things. And I think that helps with a lot of buy-in about changing thinking and those strategies. And so I tend to put all of those behavioral interventions first and then go more to the cognitive. So behavioral intervention, one is like relaxation training. So obviously one of the best ways to disrupt that cycle is targeting stress center, stress response. Everybody knows about deep breathing, and I'm sure has taught that to many clients. Progressive muscle relaxation is included in this. I would say it's not the typical like progressive muscle relaxation that we might use with other clients, just because the tensing and releasing muscles are good for stress and anxiety when we do that with those patients. But for chronic pain, we don't want them creating more tension or more pain. So I would say it's more like a body scan. So if you're familiar with a body scan, these are really great. You can Google them. You can get kind of like, lead body scan videos, recordings for your patients to use at home. I usually go through one in session in that point in the model. And with the body scan, I like to just have people notice that muscle. And instead of tensing it, we don't talk about tensing it. We just talk about relaxing it. So they notice that muscle and then they feel themselves relax it. So you're not actually creating more tension or pain. And then physical activity and activity pacing, right? We assess kind of the harm versus hurt. And pain wants to tell us like there's something dangerous or alarming, right? So with chronic pain, though, those signals are old. So I kind of think it's helpful to think like a smoke detector, where the batteries are dead and it keeps going off. And you hear that beeping. It's like that signal is old. It's not signaling what pain normally does, which is dangerous or alarming, right? It's just that signal to us that there's pain. So when we don't use our muscles, it also doesn't take long to atrophy. So they get weaker, joints get stiff. So we talk to people about the physical activity, right? Sometimes just walking to the kitchen or the mailbox, it's more painful than it would normally be because they've been resting, they're not using their muscles, and that's part of the problem. So with this behavioral intervention, it's really talking with people about increasing their physical activity. Oftentimes, right, they avoid using their bodies because they're trying to avoid further injury is what they think, when in reality, not being active is making the pain worse. So you can validate their experience, right, of how they balance pain and physical activity. It makes sense that people wouldn't want to do things because it hurts and then they're not doing so much. But we have to talk to them about what chronic pain means and that it's not necessarily doing more damage for them to move, and how to balance that activity. So one of the helpful ways I think is to talk to them just about their activity patterns. And here's just some common patterns. This is overdoing it and crashing. So The blue line is your activity level, and the red line is pain. So as their activity level goes up and increases, obviously the pain increases. And a lot of times when people are doing tasks that they need to do, they might continue even though they're getting worsening pain. They might be hurrying through it, and they don't even notice the pain until they're done. They stop, and now it's like, oh my gosh, they're in excruciating pain. So we can see then how the pain line continues even though the activity has stopped. And so then they crash, right? They stop, their activity plummets, their pain level stays really high, and they're crash. They're in this recovery period. And this becomes a prime time for that depression and anxiety to set in because they're on the couch, they're in bed, they're not able to continue with tasks. They worry about things getting done or being at work. Then as pain comes down, they immediately go back to doing things again, crash again. And so this pattern repeats. You can ask patients if they see this in themselves. Most patients that do this pattern do recognize it. Then there's also the rest and wait pattern, where we can see like they just don't do activity. It's like they're worried about making the pain worse, and so they're not active. And you can see the pain is still going to ebb and flow, maybe go up and down, but they're not doing anything. This is where depression is really high with this pattern, right? People just aren't engaging in their lives much at all. So we want to talk to them about a balance, and there's actually middle ground in between these things of doing nothing or doing too much. The two types of interventions that are helpful with this are time-based activity pacing. So you identify an activity. It's like something you either really enjoy, or it could be something that you need to do, like chores, and something that often causes you maybe to overdo it. So then you have the patient estimate how long they can actually do the activity without creating too much pain. And that's their active time. Then you work with them to estimate on how long they need to rest before becoming active again to prevent increased pain. And this is their break time. So they keep alternating between active time and break time until they complete the activity. So for example, if somebody was going to maybe do laundry and they're like, I can only do one load, or I can put something in the washer and dryer, and then I rest during that time. So then I could go back and get it out of the dryer and do it. Or maybe they're doing chores or cleaning, and they estimate how much time they can actually be active with a rest, a break time, and then go back to activity. And I think what's really helpful, patients often get confused, like meaning break time, they just have to sit there and do nothing. And it doesn't. It means break time from that activity or break time from things that affect that pain. So they might have other activities or things they're doing in between that, but it's a break from either that actual activity or things that increase their pain. Same thing as cue-based activity. It's similar. You identify that activity, and then instead of the actual time doing it, that there's like a cue, and you rate your current pain on a scale. And then it's, you never want your pain to increase more than 2 points. So they start the activity, they rate their current pain, let's say as a 4, and then they do the activity. And as soon as they feel like their pain is self-report at a 6, then they would know that they would need to rest and use break time before they resume the activity. And so time-based or cue-based, whatever seems easier for patients, some gravitate to one or the other, or might be more helpful depending on the activity they pick. Okay, so then we get to the cognitive interventions. And a lot of us, I'm sure, are familiar with the ABC model, right? Within CBT framework, it's our thoughts, beliefs about the world and events that drive our emotional responses. It's really our beliefs that also drive our physical reactions. Events get responded to as stress, and that affects our behavior. So one possible way to explain it to patients is just talking to them like, you know, we've discussed things you can do physically to manage your pain, such as walking and engaging in activities you enjoy. Today, we're going to also talk about something different, how your thoughts can affect your pain and how changing them can help improve your satisfaction with life. So I would ask them, you know, when you're in pain, what kind of thoughts go through your head, right? And explain to them in general, we find as pain gets worse, obviously thoughts get more negative. And research even shows that negative thoughts actually increase pain. They also get in the way of doing things we know help make pain better. So unhealthy thoughts lead to unhealthy choices. Everyone has negative thoughts, and often these are automatic. For example, right, a lot of patients with chronic pain think my pain is never going to get better, or I can't do anything with this pain. So embracing these thoughts then might lead to avoiding activities, people, right? Makes it less likely they're going to use their pain management skills. And it's that chain reaction of negative, unhealthy thinking, feeling upset, avoiding, not using coping skills. And that's the cycle we're trying to break here. So with them, I just, highlight the connection between how we think and how it affects us physically, emotionally, and behaviorally. We just help patients see those connections, and helping them recognize them on their own is really helpful. Then once they're tracking their thinking with maybe like an ABC sheet like this, then you can go through it together. So for instance, this was one of my clients, kind of simplified, but her activating triggering event situation, she reached down to pick up the laundry basket and had severe pain in back and legs. And her thoughts were, why me? What did I do to deserve this, right? Oh my gosh, it's going to be a long day. And her meaning and interpretation was, I'm not a good mom. I can't even keep the house clean. My kids are embarrassed of me. And then we can talk about those consequences, right? The emotions feeling because of that. She was feeling sad. She was feeling angry, ashamed. Some, it's really helpful to talk about their physical sensations, how they can recognize that, especially if people aren't used to emotional identification or expression, but knowing that there's like a flushed face, hot, her tearing eyes, where is she feeling that in her body? And then also like behaviors, moving very slowly to avoid pain, not wanting to continue tasks, and then ends up just laying on the couch for the day. So the common cognitive errors that we see are things like catastrophizing, should statements, all or nothing thinking, that overgeneralization, jumping to conclusions, emotional reasoning, disqualifying the positive. A lot of us that use CBT probably recognize what type of thoughts these are and patterns. I think it's helpful for people to learn patterns because it makes it easier to catch themselves in that type of thinking. So I will often use a sheet like this that has those different types of unhelpful thoughts on it and those patterns, so people can really identify, oh yeah, I'm somebody who does catastrophizing. I believe the worst, right? And then they'll pick that up. Or people who use a lot of should statements, might use that then in session, be like, oh yeah, I shouldn't say that, right? Like it's not a should thing. It helps them to be able to see maybe what kind of patterns that they have in their thinking. It helps them identify and be able to come up with, more helpful thoughts and cognitive restructuring. So that intervention, kind of identifying the helpfulness of the thought, like, is it helpful? Is it harmful? Some thoughts might be helpful to them, and that's helpful for us to identify, acknowledge, and be able to use those. And then if the thought is harmful, we talk to them about how we challenge it. So if you use something like this is a cognitive restructuring worksheet. You put the situation in first and have them identify what the situation is. For this patient, it was sitting down at the end of a long day at work. Pain is 8 out of 10. And I have patients rate it because I just think it's helpful to put a number on it a lot of times so that they can see the difference in things. And then we talk about their automatic thoughts, right? I can't do anything to help the pain. It's never going to go away. What if I can't work? This specifically came from a patient with fibromyalgia because there was a lot of feeling of no control over it, and this concern that in the future, if they can't work, how are they going to support themselves or a family? The emotions, they were feeling frustrated and worried, about 90% frustrated, 95% worried. So we talk about evidence for what's the evidence that this thought is true. And they said, I have pain every day, and some treatments I've tried don't work. So there is some evidence. A lot of times, right, we want to validate that for people, that some of those thoughts are true. Part of that thought is true, right? And then what's the evidence against it, that this thought is false? Well, we know that this person was able to identify some things help, like staying active, but not overdoing it, and pacing myself. That was a big thing for him. Then we talk about the positive coping thought. He was able to identify there are things that I can do to manage the pain. I have a plan. This was really helpful for him just to acknowledge he has a plan. If there is pain, it's kind of that acknowledgement like there's things I can do. I have a plan to manage it and I know what to do when it happens. And that was that piece that we could really help him with that sense of control over too. Can't always control the pain. There are things we can do to manage it. And he did have a plan. And using that coping thought, then frustration went down to like a 75%, worried went down to like a 60%. So that's how you would use that like cognitive restructuring. Behavioral intervention, sleep education, and sleep hygiene are super important. I do a lot of psychoeducation about sleep habits and that basic sleep hygiene, right? You want to set a bedtime, awake time, limit stimulants, limiting activities in bed, encouraging that pre sleep routine, limiting light or screens, and that 20-minute rule. And obviously, we could go into a lot further detail about these, but just that idea of including that as a module or a session I think is very helpful in this model because oftentimes we know sleep causes more pain and people who have chronic pain often have a lot of difficulty sleeping, which is really important for our mood and activity. So that is it for my presentation.
Thank you, Kelly. Sorry, thanks, Kelly. That was great. Any questions, thoughts, comments for Kelly? Feel free to unmute and ask those or drop them in the chat, however you feel comfortable. Just kind of pause here for a minute and see if anyone has any questions.
Sure.
Any workbooks that you recommend as far as that goes and where to access those?
I don't have any workbooks. There are manuals. If you look up like CBT, CPP, like the manualized, you can find like manuals for sessions. I don't have any specific workbooks. I think I use more just the general CBT, like ABC and cognitive restructuring worksheets like that. I tend to do that just because I use CBT a lot in my other work. But yeah, I don't have any specific workbooks that I've used, but I'm sure there are out there. There are manuals for the model that will take you session by session too.
Kelly, would you be okay if I shared your slides? I know there's some useful tools and resources in there. If you wouldn't mind, that might be helpful for folks. If I could do that.
Sure. Yeah.
Thank you. Thank you. Okay. Well, anything else for Kelly?
So let me say a few things here.
Yeah.
As as you all know, oh, there's a question. Go ahead. I'm sorry.
Yeah. See, we got a question in the chat. Are there common barriers that you might have suggestions on overcoming?
Yeah, I think a lot of common barriers are people with pain often have been not heard or listened to, or like, not really been validated about their pain they're experiencing, or been told like there's nothing else they can do. And so I think one of the biggest barriers is getting people in and recognizing like what CBT, CP can do and building that rapport. People come in, oh yeah, I'm just going to think different. That's going to make my pain go away. Or they have misconceptions about what you're trying to do. And we're not solving their pain. We're not taking their pain away, right? It's a lot of psychoeducation about what we're able to do to help manage it, maybe make things a little bit better, and how to interact and enjoy their life and have a higher quality of life. So I think one of the biggest barriers is getting people in and willing to do it. And then you got to build that rapport and kind of talk to them about the model and what the goals are. I think that's probably one of the biggest ones.
Great, thanks. And there was a question from Kayla I missed in the chat about sharing the recording, and so yeah, I responded to that. I'll be sending out the if you want the recording, just let me know and I can send that out to you on Monday. Okay, Dr. Stoll, I'll let you go ahead.
So, if you think about people that have chronic pain, you're going to run into these individuals because it's so common. And depending on kind of the studies and the group you look at it's anywhere from 50 to 100 million people in the US, which is a lot of people. And so Kelly did a great job of kind of not only describing the basics of chronic pain, but really how to approach these individuals and work with them and get them to come back and get them to focus on kind of things that will work for them that they value that they can kind of commit to get them to come back to work on things because a lot of these individuals struggle and there's huge comorbidity. The neuropathology or circuitry within our brain, you can't separate really the emotional stuff from the physical stuff. And so many of these individuals, as she's alluded to, not just come in with pain, but with depression. And so I want to thank her for kind of going through things, not only from the pain aspect, but how to approach. She gave some great examples that are very practical. And the challenge for these individuals is not just to have them come in and be put on a pain medicine because that's short-sighted and um, they'll continue to struggle. So thank you, Kelly, for doing this. Now, Will and I want to change gears a little bit here, and we want to talk a little bit about, as a reminder, I think most individuals on the call here have received some of the money from the uh, integrated healthcare program. And our funding cycle ends in 2027. However, it looks like based on kind of some of the success that has happened, and Will can give you the numbers, that we continue to grow and our key is not only growth, but it's really keeping you all where you're at and hopefully happy and working. And so it's the sustainability or the maintenance component. Now, to add to that, the real transformation funds are, I think most of you have heard of the Rural Transformation Funds, and it looks like we're going to get additional money for those. So I'm going to let Will elaborate on that. I really wanted to just kind of put the segue to that. Will can talk the details, and I particularly wanted to thank Kelly for her presentation today.
Yeah, I'll echo that. Thanks, Kelly. Yeah, I have just like one slide here that I could share that kind of says a little bit about the Rural Health Transformation Funds. I'll just share this one here. Okay, so yeah, our project, like Dr. Stoll mentioned, we're going to get a small portion of the RHTP funds. We're still waiting on our contract. It's supposed to come at some point this summer. And so, as Todd mentioned, this would allow us to kind of expand our reach with helping clinics, rural clinics, in this case, start up behavioral health provider positions. I, the amount of funding we're getting will kind of let us about double our impact. So currently um, I think we've done about 10 to 12 startup funding, 10 to 12 providers. We've provided startup funding for those providers per year. That's kind of what our relatively small amount of funding has led us to do. With this RHTP funds, Rural Health Transformation Program funds, I think we can roughly double that. So yeah, well, we'd be trying to aim for 20 new providers per year out in rural Nebraska. And rural Nebraska for these purposes of this grant, it's just anywhere outside of Lincoln and Omaha. So pretty broad definition of rural Nebraska. The one sort of caveat with the funds, at least for this first year that we'll have them, we've got some focus areas that we have to hit. So you can see those in my slide here. Those 5 areas: treatment for patients with substance
Hey,
use
Will, we can't
disorders.
see your slide,
Oh, huh,
or I
thank you.
can't.
No, that's probably because I forgot to share it. Thank you. Okay, there it is. Okay. Um, Sorry about that. So yeah, I'm just talking about our focus areas here with this grant. We've kind of got 5 areas. We may be able to expand that, but it's kind of for this first year, we've got to make it somewhat specialized. So those 5 areas again here: treatment for patients with substance use disorders, chronic pain management, women's healthcare, pediatric healthcare, geriatric healthcare. So I think those are pretty broad. Yeah, I think, most of what behavioral health providers are doing are touching on one or more of those areas. So really kind of how I'm thinking about it is probably just a little bit of extra data collection to show that we are, helping meet the needs of these patient populations. I think we could also, add in some other kind of special populations. For complicated reasons I won't go into, we're supposed to make this look a little different than what we're currently doing. And so we've kind of our focus is on kind of hitting some of these special populations in rural Nebraska. Um, okay, I will stop sharing my screen now. Dr. Stoll, is there anything I'm missing with that announcement, or anything else I should add? We should add.
If you have a site that's been funded, which I think is pretty much everybody here, it still makes you eligible if you have some interest in these areas. So it doesn't mean we have to start a completely different location or what have you. It could be where you're at if there's an expansion or development of complementary or additional services.
Yeah, thanks. That's a great point. So we'll kind of keep y'all updated. Maybe next month or two, we will know more about kind of the state of our contract. Once we get the contract, we'd be just ready to get the funds out. So kind of please be thinking on how you might be able to expand some of your services, bring in another provider, something like that, and just let us know. We'd like to get kind of give our current partners first crack at this. As Todd mentioned, we want to keep you guys going and keep things moving in a good way. Um, Other than that, I don't know if I have much to add on the rural health transformation funds. We'll just keep you updated at these meetings and through emails as we know more.
Let us know if we can help with anything, and thanks for joining today.
Yep, absolutely. Um, So yeah, I will be sending out certificates. I think I've got everyone who needs a certificate. So keep an eye out for that. Those certificates on Monday. I'll send out Kelly's helpful slides as well with that. So if there's anything you need, please reach out. Thank you and have a great weekend.